Now you can start. Go ahead.
All right, welcome everyone, and thank you for tuning in. My name is Matt Mason, and I am an infectious diseases pharmacist at the University of Kansas Health System. And with me, I have Lucy Shun, who is a critical care pharmacist at KU as well. And so today we're going to be talking about SARS-CoV-2 and COVID-19. And so for the first half of the presentation, I'll be focusing on some background information, talking a little bit about coronaviruses in general, some epidemiology, transmission, pathogenesis, diagnosis, and a little bit on treatment. And then Lucy's primary focus will be on the management of ARDS, particularly in patients with COVID-19. And so SARS-CoV-2 stands for Severe Acute Respiratory Syndrome Coronavirus 2. And this is the virus, and the disease that it causes is COVID-19, which stands for Coronavirus Disease 2019. And you can see where I've underlined how this corresponds to the specific acronym. And this is an enveloped RNA beta coronavirus, and I'll explain what a beta coronavirus is on an upcoming slide. It's thought that patient 0 contracted the disease somewhere in either late November, early December in Wuhan, China, which is the capital of the Hubei province in northern China. And for those of you that are unfamiliar with Wuhan, it is a massive city, a population of roughly 10 to 11 million people. So it's actually larger than New York City. And as of probably just a couple of minutes ago, I updated these statistics, but as of today, there's roughly 1.5 million cases, around 90,000 deaths in 200 different countries worldwide. And unfortunately, the United States, we're home to about 1/3 of all cases with roughly 15,000 deaths. And unfortunately, by the time this presentation is over, those numbers will probably significantly increase. And SARS-CoV-2 shares about 80% sequence homology with SARS-CoV-1. And this is the virus that caused the initial SARS outbreak in Asia in 2002 and 2003. And it shares about 50% sequence homology with the Middle East Respiratory Syndrome, or MERS coronavirus. And this is a graphic that was put together by a scientific journalist at Forbes. And I really like it because it displays the chronological order of pandemics on the left-hand side, and then the overall fatality rate of the various pandemics on the right-hand side. And you can see that for the past 2,000 years, really, there's been a number of different pandemics that have threatened the human population. And starting at the top down to bottom, it works in chronological order. On the right-hand side, again, it's displayed by the overall fatality rate, the larger graphic corresponding to the higher fatality rate. And so the bubonic plague in history has been the most fatal pandemic of all, killing roughly 200 million people, around 1/3 to 1/2 of all of Europe's population. And there have been a number of other very fatal pandemics as well, including things like smallpox, Spanish flu, which occurred roughly 100 years ago. And then there's still pandemics that are still occurring, things like HIV, AIDS, even MERS. And down here, you can see the novel coronavirus fatality rate. When this was put together in mid-March, obviously it's much lower than where it is today. So just take all of these with a grain of salt. There are a number of different coronaviruses, and I think it's unfair to just talk about SARS-CoV-2 without mentioning the other coronaviruses, because they've really been infecting mammalian hosts for hundreds of thousands, if not millions of years. And they don't just infect humans, they infect a number of different species. They infect rodents, they infect felines, camels, bats, a number of different mammalian hosts. And they don't always just cause severe disease. We know SARS-CoV-2 causes severe disease, so does SARS-CoV-1, MERS, but there are a number of coronaviruses that are associated with things like the common cold. And in fact, a lot of your respiratory viral panels that you use as rapid molecular diagnostics at your institution probably do include a number of different coronaviruses. So these are nothing new. So on the right-hand side, you can see how the coronaviruses are divided, and they're divided in terms of lineage, which are then subdivided. But the lineage really refers to the type of receptor that the virus uses to gain access into the host cell. So your beta coronaviruses use the ACE2 receptor, which stands for angiotensin converting enzyme 2. And so SARS-CoV-1 uses this receptor. SARS-CoV-2 also uses the same receptor. So when this study was initially published, you see a question mark there because they weren't entirely sure, but given that it shares around 80% sequence homology with SARS-CoV-1, the authors thought it was going to use the ACE2 receptor, but a number of different studies have corroborated that this virus does in fact use the ACE2 receptor to gain access into the host cell. This slide is looking at a basic epidemiologic concept called the reproductive number, or the R0 value. And this refers to the number of newly infected individuals that will occur from one sick person. And so right here in the middle, this yellow circle refers to your one sick person. The surrounding red circles refer to the number of newly infected cases that will occur because of that one sick person. And they range from something that has a very low R0 value like MERS and something that has an extremely high R0 value like measles, an R0 value of roughly 14 or 15. And so there are a number of different things that can affect your reproductive number. One would be transmissibility and the mode of transmission, and two would be the overall fatality of that infection. So the higher the fatality rate, the likelihood that the R0 value is going to be low, because the more fatal the infection, the more quickly it kills the host, the lower the likelihood that it's going to spread. And that's something that we see with MERS, Ebola. These infections have extremely high mortality rates. Roughly 40 to 60% of individuals that become infected with these viruses will pass, unfortunately. So they have low R0 values. SARS-CoV-1, the best evidence suggests that the R0 value is roughly 2 to 3. I will say there was a report published yesterday suggesting this value might be a little bit higher. I think at the end of the day, we won't exactly know what the true R0 value is until years after the pandemic is over, and epidemiologists and virologists can go back and look at the models and come up with a more accurate prediction. But as I said before, best evidence suggests that the R0 value is somewhere around 2 to 3. Another term that gets thrown around a lot with epidemiology is incubation period. And this refers to the time difference from when an individual becomes infected and when the individual will display symptoms. And so not all patients that become infected with SARS-CoV-2 display symptoms, but of the individuals that do display symptoms or that will display symptoms after an infection, the median incubation period is roughly 4 days. Now, there are some people that will display symptoms earlier, some that will display much later. Sometimes it takes up to a week, maybe even 10 days in some patients. But in general, the median value is roughly around 4 days. And the concerning thing with SARS-CoV-2 is it's somewhat stealthy, because a patient is most infectious typically a day or two after they're infected. However, these patients are most likely to be completely asymptomatic, so they don't even know that they're infected, and they're out in the community potentially spreading the virus around. You contrast this to something like SARS-CoV-1 or even influenza, in which the patient's incubation period is much shorter, and so they're likely to be most infectious when they're sickest. And so they're already likely to be in quarantine. So that's maybe can in part explain as to why we're seeing such rapid transmission and why asymptomatic spread is the likely reason that we're seeing such rapid transmission of SARS-CoV-2 throughout the world. So as I said before, there are a number of different animal reservoirs of coronaviruses, and SARS-CoV-2, it's thought that it derived from 2 SARS-like coronaviruses that are found in bats, because they share about 88% sequence homology with those 2 bat-derived SARS-like coronaviruses. And so it's thought that zoonotic transmission is what started this. So an animal infected a human, and then human-to-human transmission is really what's ignited this spread to the pandemic worldwide. And respiratory transmission is thought to be the primary mechanism of transmission. So you come in close contact with someone who's infected, they either cough, sneeze, potentially even breathe or talk on an uninfected individual that can infect that previously healthy individual. Contact with contaminated surface droplets, a surface that's contaminated with someone that coughed or sneezed on it, or they coughed on their hands, they then touch a countertop, a mouse, keyboard, doorknob, etc. That then uninfected individual touches their eyes, face, nose, whatever it may be, they then infect themselves. In terms of the primary target of SARS-CoV-2, it's thought to be the lung epithelial cells. And the reason for this is that these cells display the highest density of ACE2 expression. And as I said before, ACE2 is the primary protein that the virus uses to gain access into the host cell. However, ACE2 is expressed pretty much everywhere throughout the bodies in various degrees of density. It's expressed not only in the lung epithelial tissues, but renal cells, cardiac cells, liver cells, even some areas of the central nervous system display ACE2. So that can in part explain why we see such varying degrees of disease manifestation in some of these patients, particularly patients that have severe disease that's disseminated. That may explain why we see extrapulmonary complications in some of these patients. So here is a graphic that is breaking down the pathophysiology of SARS-CoV-2. So up here we can see the viral particles. They gain access to the lower respiratory tract. They then spread. They use ACE2 to gain access into the host cell. They then start to replicate. And then this triggers an immune response from the host. Some good things, some bad things. So we have some degree of cellular immunity and some degree of humoral immunity, with ultimately the production of IgM and IgG antibodies. So that's a good thing. But a bad thing is we have a increased production of these pro-inflammatory cytokines, things like interleukin-1 beta, interleukin-6. These trigger a pro-inflammatory state, which can lead to severe disease progression and tissue damage if left unregulated. And there are some things that we can potentially do to manipulate this, particularly around the manipulation of interleukin-6, which I'll talk about on an upcoming slide. But if left unchecked, this is what leads to ARDS, septic shock, multi-organ failure in patients with critical disease. So in terms of presentation, as I said before, some patients have no symptoms at all, and some patients have fulminant symptoms, ARDS, septic shock, multi-organ failure. In terms of the asymptomatic rate, I think it really depends. It depends on the geographic region. It depends on the host. Your younger, healthier individuals, these are the individuals that are likely to be completely asymptomatic or have extremely mild symptoms. And then your elderly individuals with a lot of different comorbidities or pre-existing conditions, these are going to be the patients that most likely have symptoms. Not every single case results in mild, or most cases do result in mild symptoms. Some reports estimate anywhere from 80 to 85% of patients will have mild symptoms that don't require further care, no hospitalizations, et cetera. However, you think about it, if that's 20% of your population that's all becoming sick within a relatively short time period, you can quickly cause an overburden of your healthcare system and overwhelm your healthcare system if all of these patients are seeking treatment at the same time. And we're definitely seeing that in various parts throughout the world, areas like Spain, Italy, even in parts of the United States, areas like New York, Detroit, New Orleans. We're seeing how quickly this can overwhelm the healthcare system if you have a bunch of sick individuals seeking treatment at the same time. In terms of your typical signs and symptoms, fever is probably the most common manifestation of disease that you'll see in these patients. Anywhere from 95% of individuals will manifest a fever at some point through disease progression. Cough, dry cough is also very common in these patients. Some less frequent signs and symptoms you may see: myalgias, diarrhea, nausea, and vomiting. In terms of typical presentation, some patients will have all of these symptoms, some patients will have none, some will have a few. So it's just important to understand that there may be atypical manifestations of disease in some of these patients. I think a lot of different news outlets, journals have said, this is a disease that only really affects elderly individuals, those with pre-existing disease, and that's not necessarily the case. We're seeing a number of different otherwise healthy younger individuals with very severe, even critical manifestations of disease. So I don't think it's fair to say that this disease only affects those individuals. However, we have seen that the patients with risk factors, elderly individuals, these are the ones that are most likely going to have a poor outcome. And the overwhelming majority of fatal cases are in individuals that are elderly, individuals that have pre-existing conditions. So individuals greater than 60 years of age, respiratory disease is a huge risk factor. Obviously, it's a respiratory viral illness. Someone with pre-existing respiratory disease is at very high likelihood of a poor outcome. Diabetes, cardiovascular disease, chronic kidney disease, cancer are all independent risk factors for severe disease progression. I think one that's getting a lot of attention, especially as it's affecting more and more Americans, is obesity. And so anecdotally, we've seen individuals with high BMIs, greater than 35, greater than 40. These are the individuals that have to be intubated. And the patients that are intubated, it takes a long time to wean these patients off of the ventilator if they have very high BMIs. And there was a study that was just published in China a couple of days ago, and they found that individuals that had a BMI greater than 28 had roughly 3 times higher risk of severe disease manifestation than individuals that had a lower BMI. So in terms of clinical presentation, this is looking at the median number of days for a specific event to occur, looking at patients from Wuhan, China. And so patient will typically become infected and roughly 4 or 5 days later start to display symptoms. An overwhelming majority of patients will not seek hospitalization right when symptoms occur. It generally takes a couple of days for patients for their disease to become severe enough to where they would need hospitalization. And I would say the most likely reason that a patient's going to need hospitalization is for progressive shortness of breath. Yes, there are times when it's progressive fever or persistent cough, but an overwhelming majority of times it's patients that have progressive shortness of breath. And then from there, a couple of days later, patients can progress to ARDS and then admission to the ICU and then potential intubation mechanical ventilation. Some patients will progress earlier, some it will take later, but this is the general course looking at median values from patients in Wuhan. There's another study looking at patients from Wuhan, and it's trying to look at lab values and their ability to predict whether or not a patient will have severe or non-severe disease. So this is looking at values from 452 patients. And all of these values were things that correlated with severe disease manifestation. So patients with severe disease are more likely to have a higher white blood cell count. They're more likely to have a higher neutrophil, absolute neutrophil count, and higher neutrophil percentage. Conversely, they're likely to have a decreased lymphocyte count and a decreased lymphocyte percentage. So what we're seeing is a shift, a dysregulation of their immune response, if you will. So a higher neutrophil to lymphocyte percentage. And I think the story that this is trying to illustrate is that we have an increased amount of cells that secrete things like pro-inflammatory cytokines, like your neutrophils. And then we have a decreased amount of lymphocytes, particularly your regulatory lymphocytes, that help to mitigate that pro-inflammatory response. And so we have a shift in the number of cells that secrete pro-inflammatory things, and then a decreased number of cells that try to decrease inflammation. And so what ends up happening is you have this pro-inflammatory state, and that's why we see such high serum ferritins in these individuals and such high CRPs and interleukin-6 in patients with severe disease manifestation. So this is a typical clinical presentation looking at survivors versus non-survivors. And again, this is looking at median values from patients in Wuhan, China. So 200 patients overall were included in this study. 145 of those were survivors, 55 non-survivors. And you can see that survivors, non-survivors, sepsis, ARDS typically manifest around the same time, but your non-survivors, these are the people that are likely going to have those extra pulmonary complications. So they're going to have acute cardiac injury, acute kidney injury. Patients that are ventilated may have a secondary bacterial ventilator-associated pneumonia. And then death usually occurs around 3 weeks into a hospitalization. Sometimes it's sooner, sometimes it's later, but in general, it's around 3 weeks into a hospitalization. And so this is from the same cohort of individuals. And again, it's trying to look at lab values and their ability to predict whether or not a patient's going to survive versus a patient that's likely going to die. And so these are broken down into your survivors in blue and then your non-survivors in red, looking at key lab parameters. So starting in the top left-hand corner, we see our D-dimer values. And so survivors may have a somewhat elevated D-dimer, but your non-survivors, this is when we really start to see a separation in their laboratory values. And so we really start to get concerned once the D-dimer values hit 15,000, greater than 20,000, puts a patient at significantly higher risk for fatal disease. Next, in the middle, we see lymphocyte count. And I think this is probably the best predictor. Time and time again, each study has shown that the lymphocyte count is probably the best predictor as to whether or not a patient will have severe or non-severe or even fatal disease. And so again, stratified your survivors in blue, non-survivors in red. And so survivors, they may present with a somewhat reduced lymphocyte count, but their lymphocytes typically recover around a week or so into their disease progression. But your non-survivors, these individuals are more likely to never have their lymphocytes recover or even decrease from when they initially present. IL-6 value, so in the bottom left-hand corner here. So a typical IL-6 value is a value of less than 7. So you can see that your survivors may have a somewhat elevated IL-6 level, but it's not typically multiple times the upper limit of normal. Once that occurs, that's when you're likely to see those more critical cases. So we really start to get concerned once the IL-6 value is 3-5 times the upper limit of normal. So values of like greater than 20, greater than 30, that puts a patient at significantly increased risk for fatal disease. So serum ferritin again. So survivors may have a somewhat elevated ferritin level, but patients with fatal disease are more likely to have significant elevations in their ferritin. So values of like greater than 1,000, greater than 1,500, these are where we start to get concerned. This is a study that was actually just published a couple of days ago, and this was done in Munich, Germany, and it was trying to predict lab values and their ability to predict whether or not a patient was going to progress to respiratory failure and need intubation and mechanical ventilation. And they looked at a number of different lab values, so LDH, D-dimer, CRP, but they found that the best predictor for the progression to respiratory failure was the interleukin-6 value. And so looking in the right-hand part of this slide, you can see that a maximal IL-6 value before intubation, a value of greater than 80, significantly predicted the progression to need mechanical ventilation. And this value, individuals that had a value of greater than 80 were 22 times more likely to need mechanical ventilation than individuals with an IL-6 value of less than 80. So I think this does display how pivotal IL-6 role is in the manifestation of severe disease. So diagnosis, it's important to take a number of different things into account when trying to make a diagnosis. So patient history. So I think travel history was very important in the beginning of the pandemic, but now that it's in pretty much every country, and then in the United States, in every city, in most counties, I think travel history is not extremely important. I think it's definitely, you need to take it into account, but community spread is so important for these patients. So I don't know if travel history is as important as it used to be. We know household exposures, known close contacts are at significantly elevated risk, and then healthcare workers, first responders at a much higher risk as well. Take into account your clinical presentation. So do they have the typical signs and symptoms of COVID-19? It also depends on whether they have upper or lower respiratory tract infection. And then again, your symptoms can range from someone completely asymptomatic to fulminant symptoms, ARDS, septic shock, multi-organ failure. Imaging is very important here. So as our radiologists get more and more comfortable, I think they're starting to call out, patterns suggestive of COVID-19. And I'll show you what they look like on an upcoming slide, but it really depends on disease manifestation and progression. So typically early in a course, patients asymptomatic, they may have unilateral ground glass opacities. As it starts to spread and patient becomes more symptomatic, particularly patients with lower respiratory tract disease, they have bilateral manifestations of disease, and then diffuse involving all 5 lobes in patients with moderate severe disease. And then patients with critical disease typically have focal consolidations with surrounding areas of ground glass opacities. Molecular assays are very important in our diagnosis. So most institutions are using PCR-based assays to detect RNA genetic material from SARS-CoV-2. There's also some humoral assays looking at humoral immunity, so IgM, IgG antibody detection. Some labs are in the process of developing those tests as well. So here are your radiographic findings, and these are, they correspond to whether or not a patient had a fatal case, and it's looking at earlier versus late manifestations of disease. And so in the top left-hand corner, you see a patient with fatal disease and see some bilateral manifestations, bilateral ground glass opacities, but you can see how the disease progressed and it's diffuse. And same with, top right-hand corner, this patient's fatal case, you can see bilateral manifestations, but diffuse ground glass opacities just a few days later. And I'm sure if you were to continue to scroll through the CT of the chest, you would see diffuse ground glass opacities in all 5 lobes. And then you can see, contrast this to patients that have recovered cases. So, looking at this patient in the bottom left-hand corner, day 4 versus day 7, you see a little bit of progression, but not nearly as pronounced as in the, top row. And then in the patient in the bottom right-hand corner, you can see some focal consolidations with ground glass opacities here, but these do appear to resolve. The focal consolidations are getting much smaller, and the ground glass opacities are starting to resolve in a few days. So the number one way to stop the spread of disease is through disease prevention. Washing your hands is probably the most important thing that people can do here. Make sure you're using soap or hand sanitizer that's at least 60% alcohol based. If you're using soap, make sure you wash your hands for at least 20 seconds. And don't forget to hit those areas that are frequently missed. So things like fingertips, underneath the fingernails, back of the hands, thumbs, these are areas that are often missed. Avoid touching your eyes, nose, and mouth. Make sure you avoid close contacts and practice social distancing. Cover your coughs and sneezes, and then make sure you clean and disinfect your frequently touched surfaces. So as I said before, these would be things like countertops, door handles, light switches, your mouse, keyboard, phone is another big one. So make sure you visit the Environmental Protection Agency's website. If you're not sure whether or not your product has activity against SARS-CoV-2, they have a really nice list there. And then in the bottom left-hand corner, you can visit the CDC's website that has all of this information. I think they also have a link to the EPA's website. So next I want to talk a little bit about treatment, and there are a number of potential different treatment modalities here. I really want to focus on your small molecules, and then of your small molecules, things that inhibit viral replication, and then things that can potentially inhibit RNA synthesis. I'll talk a little bit about IL-6 inhibition with monoclonal antibodies. I will not be talking about convalescent plasma or vaccines. There are a number of different good resources out there if you're interested. So one thing I do want to mention about treatment is there is no FDA-approved medication to treat COVID-19 or symptoms at present time. And I don't think there is likely to be a cure for all patients, unfortunately. And just knowing what we know about respiratory viral pathogens in general, I think at best our antiviral medications, they can maybe be associated with a faster time to clinical resolution and maybe in some small subset of patients prevent severe disease progression, but I don't think there's ever going to be an overwhelming mortality benefit for all subsets of patients. So I think it's just, as pharmacists, we need to manage our expectations as to what antivirals can and cannot do for these patients. And patients that have very high pre-treatment risk for significant morbidity and mortality, I don't think any antiviral is going to significantly alter their course, unfortunately. That's just not how antivirals and respiratory viral pathogens behave. There is never going to be a replacement for aggressive supportive care in these patients. And this is the most important thing we can do for our patients. And so make sure that we are optimizing the respiratory and hemodynamic status. In terms of antivirals, I'll talk a little bit about some of the things you see in that column there. So things like hydroxychloroquine, pinavirine, ritonavir, Kaletra, and remdesivir. Adjunctive therapies, so these are more likely to be seen in patients with severe disease, so we can potentially manipulate the IL-6 pathway with things like tocilizumab and sarilumab. Corticosteroids in general are not recommended for these patients. They've been studied in SARS-CoV-1, MERS-CoV, really were not associated with a significant benefit. And these patients, the risks were generally much greater than any reward. So in patients that don't have another indication to need corticosteroids, their use is not routinely recommended. So hydroxychloroquine, chloroquine. So chloroquine is a medication that is frequently used for malaria prophylaxis, but it does have some antiviral properties. So this medication can increase intracellular pH, and this can inhibit viral endocytosis because this is a pH dependent process. So the lower the pH intracellularly, the better the rate of viral endocytosis. So by increasing pH, you can decrease the rate of viral endocytosis. It also has some immunomodulatory effects. It can inhibit the production of interleukin-1 and interleukin-6, which we know are pivotal players in the cytokine release pathway. The dosing regimens, there are a number of different dosing regimens out there. The one we use at our institution is one that was published in a paper that came out a couple of weeks ago in Clinical Infectious Diseases, and it was done in a PK/PD model. And the dosing regimen that they used was a 400 milligram loading dose every 12 hours for 2 doses, followed by 200 milligrams every 12 hours for 4 days. So a total treatment duration of 5 days. Biggest toxicities in these patients, especially acutely, is QT prolongation. Some of the toxicities that you can see prolonged durations are retinal toxicities, but they're unlikely to manifest in patients that are only going to need 5 days of therapy. There is an ongoing post-exposure prophylaxis clinical trial for household contacts as well as healthcare workers that come into contact with the virus, being conducted at the University of Minnesota. I think there's another one at Duke University, so I would refer you to those if you are interested in participating. So here is just kind of a figure breaking down the activity of hydroxychloroquine and chloroquine for all the visual learners out there. But here in the top left-hand corner, you can see this is your SARS-CoV-2. This is the S spike protein, which binds to ACE2 on the host cell, which then gains access into the host cell. And so, as I said before, hydroxychloroquine and chloroquine increase intracellular pH, so they decrease the rate of viral endocytosis because this is a pH-dependent process. The lower the pH, the better this works. So ultimately, this inhibits viral infection and replication. And then you can see some immunomodulatory effects over here can inhibit the production of interleukin-1, interleukin-6, and TNF-alpha. So remdesivir, this is another medication that's gaining a lot of attention. So you can see the structure up here. So it is an adenosine analog. So you can see your adenine ring right here. There's a nitrile group attached to this ribose right here. This is a phosphoramidate group. So this is a prodrug, and this helps the molecule gain access into the host cell. Once inside the host cell, it is converted into a nucleoside by intracellular esterases. From there, it's mono, di, and then triphosphorylated into a nucleotide, which is then incorporated into an growing RNA chain ultimately inhibits the activity of RNA polymerase. It has an activity against a number of different RNA viruses. So it was initially studied for Ebola. However, the in vitro activity was good, but the clinical efficacy just wasn't there. The drug has since been repurposed. It has pretty good in vitro activity for coronaviruses, and there are a number of ongoing clinical trials for SARS-CoV-2. Biggest toxicity with this medication is hepatotoxicity, and patients with an ALT greater than 5 times the upper limit of normal are excluded from clinical trials as well as compassionate use. With regard to compassionate use, there was a program for obtaining this medication for patients with severe and critical disease manifestation. It has since dissolved, and it only exists for patients that are less than 18 years of age or pregnant. For all other patients, you either need to enroll them in a clinical study or you need to gain access through the expanded access program. Lopinavir, ritonavir, or Kaletra. So lopinavir inhibits its primary mechanism is to inhibit HIV protease enzyme, and then ritonavir is a pharmacokinetic booster, inhibits CYP3A4 mediated metabolism of lopinavir. So as I said before, the primary mechanism is against the HIV protease, but a number of different RNA viruses do have a conserved protease enzyme, and those amino acids do appear to be conserved. So if a drug has activity against one protease enzyme, it may have activity against other protease enzymes. And that's what we see for lopinavir with regards to its activity for HIV virus, as well as for coronaviruses. And so it does have in vitro activity against SARS-CoV-1, MERS-CoV, and SARS-CoV-2. It's been studied clinically for SARS-CoV-1, and there's some ongoing clinical studies for MERS-CoV. Biggest toxicity would be nausea, vomiting, diarrhea. Can also see some hepatotoxicity and QT prolongation. And this was a study that was published just a few weeks ago in the New England Journal of Medicine. It's probably the largest randomized study that we've seen for SARS-CoV-2 at the moment. So 199 patients were included in this study, and they were randomized to receive either Kaletra or the control, which was just standard care. No antiviral was given in the control arm. The primary outcome in the study was time to clinical improvement. We'll say that most of the patients in this study were pretty sick. A lot of these patients would have what we would classify as either moderate, severe, or even critical disease. A number of patients were mechanically ventilated. With regards to the primary outcome, there was no significant difference in time to clinical improvement in patients that were randomized to receive Kaletra or control. They then looked at patients that received drug, what they classified as either early, which was within 12 days of symptom onset, or late, which was greater than 12 days of symptom onset. And again, no significant difference in time to clinical improvement between the two treatment arms. When looking at the modified intention to treat population, there was 3 patients that were excluded in the Kaletra arm. So the total number went from 99 to 96. 3 patients were excluded because they died within 24 hours of randomization and never received a dose of the study drug. And so when you exclude those 3 patients, there does appear to be a trend towards a faster time to clinical cure in the Kaletra arm. There does also appear to be numerically lower mortality rates, numerically lower ICU length of stay, but the study was not powered to detect these outcomes. Another study that's gained a lot of attention is the combination therapy of hydroxychloroquine and azithromycin. And this is somewhat now of an infamous study. It has gained a lot of attention in the news. And so patients in this study received one of 3 different treatments. They received control, so no antiviral, hydroxychloroquine only, or hydroxychloroquine and azithromycin combination. Primary outcome in this study was whether or not a patient had a positive PCR at a specific time interval. It was not a log reduction in viral load. It was no clinical outcome. It was just yes or no, does the patient have a positive PCR? And so what you can see here is that there was a significantly higher proportion of individuals in the hydroxychloroquine and azithromycin arm that had negative PCRs. Particularly at day 5 and day 6, 100% of patients had a negative PCR. Contrast that to the hydroxychloroquine monotherapy and then the control arm. However, there are a number of different flaws with this study, most of which are related to their methodology. So number one, it was a very small patient population from multiple different geographic areas in France. There were 6 patients that are excluded in the hydroxychloroquine monotherapy arm. And when you look at the reasons that they were excluded from the primary endpoint, it's likely that all of these patients actually failed hydroxychloroquine monotherapy. A number of these patients were admitted to the ICU and a few of them actually died. So not very encouraging results. Second, they use a lower threshold from the standard definition of what a negative PCR is. And so how they determine what a negative PCR is they do a number of what's called cycle thresholds. And so they set up the assay, they run the PCR, and if no fluorescence is detected, they keep doing it for a number of different cycles. After 40 cycles, if no fluorescence is detected, they say, okay, that's a negative PCR. But for whatever reason in this study, they used a value of greater than 35, which in most studies, they always use a value of greater than 40. And the authors didn't state why they used a value of 35 in this study. And I'm not sure how much it would have affected results, but this is something that's not typically done. Additionally, there was only 6 patients in the hydroxychloroquine and azithromycin arm, so a very small number. Additionally, the findings were completely incidental. So there was no hypothesis or theory going into this that patients that were receiving hydroxychloroquine and azithromycin combination were going to have a faster rate of viral clearance. The reason that patients received azithromycin was just because they were receiving atypical coverage for CAP. And so there was really no rationale as to why we could potentially see a faster rate of viral clearance in these patients. With that being said, azithromycin does have some antiviral properties. It has been studied in vitro for Zika and Ebola. The in vitro activity for Zika virus does appear to be better than for Ebola virus. We're not entirely sure the mechanism for its antiviral properties, but it's never been studied clinically for those viruses. Additionally, it's never even been studied in vitro for coronaviruses, so unsure if it would have any activity against coronaviruses. Additionally, 6 patients in the control arm didn't even have a PCR done. So if these patients had PCRs done and they had negative results, I think it would have significantly altered the outcomes here, and hydroxychloroquine and azithromycin combination probably would not look as good as it currently does. And since the study was initially published, the journal, the International Journal of Antimicrobial Agents, has since retracted the findings of the study, and it's no longer included in the journal because they said that it did not meet the journal's standards for publication. They did release a letter. They didn't explicitly state why it was retracted, just that it did not meet the standards. And so I think a number of different treatment protocols and algorithms from institutions have since reflected these findings. So if it is going to be considered, I think you do have to weigh the potential benefits of combination therapy, particularly the overlapping toxicities, QT prolongation. And we're unsure of the clinical benefit, and we know this could potentially cause a lot of harm. So you definitely have to weigh the risks and benefits of combination therapy in these patients. So last, I want to talk about IL-6 inhibitors. So first, tocilizumab or Actemra. So this is an IL-6 receptor inhibitor, and it can reverse cytokine storm in patients with severe ARDS, septic shock, multi-organ failure. Big toxicities would be serious invasive infections, hepatotoxicity, neutropenia, thrombocytopenia, although these are more likely to occur in patients that are receiving routine administration of tocilizumab. For most of these patients, they'll receive 1, maybe 2 doses. So unlikely that this will manifest in an overwhelming majority of patients, but definitely something we need to keep in mind. This is a drug that is FDA approved for treatment of cytokine release syndrome in CAR T-cell patients. It's also approved in China for the treatment of severe symptoms in patients with COVID-19. And so this was an observational study. I'll show you the results in an upcoming slide, but an observational study done in 21 patients. And preliminary studies had shown that patients with severe disease had high IL-6 levels. So the authors of this study thought that by inhibiting this pathway, they could reverse the manifestations of severe disease. And that's something they definitely saw. And I'll show you the results of that on the next slide. And there are ongoing clinical trials in the United States, the FDA, as well as in Europe and European Union, to further assess the safety and efficacy of IL-6 inhibition. So this is that study I was talking about. So again, 21 patients received tocilizumab. And on this slide, you have your baseline CRP values and a few days after administration of tocilizumab, as well as your fever curve. And you can see that a majority of patients did have elevations in both of these things after tocilizumab administration. These results did normalize. And then on the left side of this slide, you can see your FiO2 concentration. So a number of patients requiring very high FiO2 concentrations. And those results did seem to normalize a few days after tocilizumab administration, or did appear to decrease. And then your oxygen concentrations did significantly increase after tocilizumab administration. And these are just improvements in radiographic findings. And these are grouped by specific patients. Each column is 1 patient. So you can see that for all 3 of these patients after tocilizumab, significant improvements in their radiographic findings. Sarilumab is another IL-6 inhibitor, brand name Kevzara. Same exact mechanism, same exact toxicities, ongoing clinical trials in the FDA, with the FDA as well as European Union to determine safety and efficacy for COVID-19. And so this is something that I would encourage kind of all institutions to create, and this is something that we do have specific to KU, but on our SharePoint, which anyone can access on our internet, we have our COVID resources, and there we have our treatment algorithm. We have our restriction criteria, particularly for our high-risk medications like tocilizumab. We also have some language about the expanded access program and compassionate use programs from Remdesivir, because we do receive requests from a lot of different physicians about how they can potentially obtain this medication. There's also some recommendations for what to do with ibuprofen, corticosteroids in patients that are on ACE inhibitors and angiotensin receptor blockers. So we have some resources there for people that are curious. And then we also have some recommendations for laboratory monitoring for our patients that are on normal wards, patients that are in the ICUs, as well as potential order sets. And so with that, I will pass it over to Lucy, who will talk about the management of ARDS in patients with COVID-19.
Sorry, for the second portion of this presentation, we will be talking about COVID-19 and acute respiratory distress. Also, I'll be saying ARDS for the rest of the time. So it's estimated that approximately 5 to 11.5% of proven COVID infections will develop severe disease requiring some sort of intensive care. These numbers are based on the severe outcomes among patients with COVID-19 found on the US CDC website that reflects numbers from February 12th to March 16th. So median duration between onset of symptoms and needing ICU admission has been roughly about 8 to 10 days. As Matt mentioned, these are some of the identified risk factors: age greater than or equal to 60, and patients with comorbidities such as diabetes, hypertension, cardiac disease, underlying pulmonary disease, obesity being a new marker for us in the US. So ARDS is a focus in COVID, more so because 2/3 of these ICU patients will meet criteria for this. And it's a diffuse inflammatory lung injury, often associated with progressive dyspnea, increased oxygen requirements, and bilateral infiltrates. So ARDS was first reviewed in a journal nearly 20 years ago and remains a relatively common and lethal syndrome. In a very recent international study involving 29,000 patients, 10% of those patients were admitted to ICU. 23% of them were mechanically ventilated with ARDS. Mortality in those subgroups with severe ARDS was near 50%, and patients who did survive this disorder had a really high risk for cognitive decline, depression, PTSD, and persistent skeletal muscle weakness. So we go into some of the classifications of ARDS. We often refer to this using the Berlin criteria. So in 2012, Berlin definition was proposed, establishing 3 risk strata based on just the degree of hypoxemia that may occur. So the first being mild, which is a PF ratio of 201 to 300, moderate with a PF ratio of 101 to 200, and severe as anything less than 100. So how do you typically calculate a PF ratio? I've included a screenshot of our ICU rounding report. At KU, we use EPIC as our EMR. So as you can see here, under our ventilator needs, the PaO2, which stands for partial pressure oxygen, which is just the measurement of oxygen in your blood, the FiO2, which stands for just the fraction of inspired oxygen, that's the concentrated oxygen inhaled. So the more oxygen a patient may require in order to achieve a sustained percent oxygen saturation, that may indicate worsening lung function. So in this example here, we'll have A PaO2 from the blood gas is 102. The O2% or the FiO2 as 60%. So because it's in percentage, we'll use 0.6. So 102 divided by 0.6 is 170. So in this particular patient, this individual has moderate ARDS. Another way of thinking about that as we transition a lot of these rapid response patients to our COVID ICU units is oftentimes we bump their FiO2 up to 100%, which we can use the number 1 in our formula. So if the patient has a PaO2 of 70, then a PF ratio of 70 is indicating that the patient has severe ARDS. So in ARDS pathogenesis, there are 3 different stages that are progressive and can be irreversible, especially in the fibrotic phase. So the first stage is called the early exudative stage. It occurs within the first 7 to 10 days and is associated with interstitial edema and just chronic inflammation. So our lungs' initial response to injury is this exudative phase. It's characterized by immune cell-mediated damage of just the alveolar, endothelial, and epithelial barriers, resulting in just accumulation of edema fluid within the alveolus. The second stage is called the proliferative stage. This occurs between days 7 to 10 up to 2 weeks from illness. And really, the goal of this stage is to restore some sort of tissue hemostasis and is often characterized by just persistent hypoxemia, low lung compliance with potential progression to pulmonary hypertension. The third stage is called the fibrotic stage and is strongly associated with the patient's need for ventilator support. It's characterized by just a loss of normal lung architecture and formation of fibrosis and cysts. So in this stage, once the epithelial integrity has been somewhat reestablished, there is also reabsorption of edema and potentially restoration of the alveolar architecture and function. So in this final or fibrotic phase of ARDS, it does not occur in all patients, but has been linked to just prolonged mechanical ventilation and increased mortality. And this is very true in some of our COVID ICU patients that we've been treating here. As mentioned before, ARDS was first journaled nearly 20 years ago, so supportive care for these patients have been somewhat established and really no different in COVID patients with ARDS. There are a few caveats, but generally the same. So the first principle in caring for ARDS is conservative fluid management. What does that really mean? In a lot of our large randomized trials, the benefit is really in the avoidance of fluid administration, especially after shock. So no maintenance fluids, and really the threshold for initiating vasopressors might be much lower. The other is cover for bacterial pneumonia until definitive diagnosis. Now, in the Society of Critical Care Medicine guidelines, this is a weak recommendation of low quality evidence. And a lot of the reasons why it's a weak recommendation is because identifying co-bacterial infections or superinfections in these COVID-19 patients is challenging. A lot of the symptoms may be similar to those of a viral infection. There's also lung protective strategies, so low pressure, low volume, typical 6 mils per kg of tidal volume. Higher the tidal volume, the more opportunity for mechanical ventilation associated lung injury. So we try to really hit that sweet spot with tidal volume. There's also permissive hypercapnia, and this isn't really a ventilator mode, it's just a strategy in allowing hypercapnia to occur, which ultimately results to lower tidal volume and, as mentioned, lower associated lung injury. So other considerations will kind of go a little bit more in depth. This is the consideration of extracorporeal membrane oxygenation. There are 2 types. The one that we have been using mostly in our severe ARDS patients is veno-venous. Really in severe ARDS with PF ratios of less than 60 with preserved cardiac function. This is a way of taking deoxygenated blood oxygenating it in the circulation and then putting it back into the body. There are case reports of high mortality in those that have received ECMO, yet a recent systematic review of 2 RCTs found a reduction in 60-day mortality with ECMO. Of note, during the MERS coronavirus epidemic, the Ministry of Health in Saudi Arabia retrospectively looked at 35 patients with refractory hypoxemia that received VV ECMO. Those patients had a lower in-hospital mortality. There are also a few drug considerations. So anything that is lipophilic, high protein binding drugs, just have a higher propensity for sequestration, meaning higher clearance or drug loss, ultimately leading to just higher requirements of the medication itself. And this is already a really big concern because it impacts a lot of our pain and sedation medications, a lot of those meds that are already hard to come by in our current landscape of drug shortages. Also of note, when contact of blood to foreign bodies, so the ECMO circuit itself, it triggers the activation of a clotting cascade. So in these scenarios, you'll often find that heparin is our workhorse agent, just used to maintain circulatory patency. Next is prone positioning. So prone positioning has been shown to reduce mortality in more or moderate to severe ARDS. This is really taking a patient on the mechanical ventilator and flipping them on their stomach and ventilating them through their stomach. So this helps reduce lung compression and increases perfusion and really has been shown to reduce mortality. The benefit is seen from reducing the risk of ventilator-associated lung injury just through combinations of more uniform distribution of ventilation and less compression of that left lower lobe by the heart. So it's recommended to do this for 12 to 16 hours. There's a lot of risk in proning patients. As you can see in this diagram, there's increased opportunity for dislodging an ET tube or an central line or a feeding tube, or even obstructing the ET tube itself and creating pressure wounds around the face, causing facial edema. These patients might be hemodynamically unstable, and this could increase that instability, can cause corneal abrasions. So anytime we prone a patient, we make sure that they have appropriate eye lubrication. And if the patient has dialysis going, then vascular access flow issues could occur when you are proning these patients. And this is also very labor intensive, and you know, at KU and a lot of other institutions really may require a team of 6 people. Our Lippincott policy requires a minimum of the nurse leader, 1 RT, and then 4 additional staff. And then proning isn't for every ARDS. It is contraindicated in patients with an unstable spine or uncontrolled intracranial pressures, or anyone with a mechanical cardiac assist device, just to name a few. And another consideration to think about is, you know, as I mentioned, just the level of involvement that, you know, it takes to prone 1 single patient. And traditionally in, you know, our ICU, we may see 1 ARDS patient, but what if you have a 14, 28-bed COVID ICU unit? That could be a potential of 14, 28 proning patients. And obviously that's not always feasible in doing that, just due to the limited personnel resource that you may have. The third is neuromuscular blockade. As compared with deep sedation alone, has been shown to reduce 90-day mortality in patients with moderate to severe ARDS, really PF ratios of less than 150. Its benefit is in just ensuring that there is patient ventilator synchrony, which in turn reduces the risk of ventilator-associated injury. There was a trial called the Reevaluation of Systemic Early Neuromuscular Blockade that randomized about 1,000 patients with moderate or severe ARDS to either receiving an infusion of NMBAs for 48 or intermittent boluses, just as an on-needed as needed basis. And really the ROSE trial showed that a continuous infusion did not improve any patient outcomes. Of note, SCCM guidelines do recommend that if you do use neuromuscular blockades because, of prone ventilation or persistently high plateau pressures, then if you do end up using continuous infusion, for doing it up to 48 hours max and keeping a deeper sedation in these patients. So there are several titration parameters when paralyzing a patient, and the goal really is to just gain a better control of the patient's respiratory effort. It can also be titrated to control shivering and ICPs, but those are really less likely things that we'll see in our COVID MICU patients. Another consideration when it comes to paralyzing a patient is the management of the patient's sedation. So sedatives are often used to reduce anxiety, stress, agitation. It's typically recommended in most ventilated patients to just do light sedation. So typically a RASS score of 0 to -2 has been associated with a shorter time to extubation as well as reduced tracheostomy rates. So we want to be mindful that patients requiring neuromuscular blockades may need to be in a more deep or moderate sedation, so RASS score of -3 to 5. Our typical choice of sedations are propofol, dexmedetomidine, followed by potentially ketamine. Benzodiazepines are typically avoided as non-benzo therapies have been associated with shorter ICU length of stay and duration of mechanical ventilation delirium. But I would say that our shortages has really impacted how we have treated some of these COVID ARDS patients, and we have reintroduced midazolam drips in some of our more complicated ARDS patients that we know will be ventilated for more than 10 days. And so this is something that we have typically tried to avoid because of past studies showing just lower mortality and outcomes in these patients, but I think it's probably going to be a little unavoidable with a lot of our shortage situations. So I won't go over the chart too in depth here in terms of sedation. I do want to point out some observations seen in these COVID patients. So many of them have been admitted with baseline triglycerides of 500. And there's been a lot of discussion across the nation with fellow critical care pharmacists about what triglyceride level would be appropriate or acceptable before we get concerned about propofol-related infusion syndrome. And some have remarked that they're comfortable with triglycerides of 1,000. Personally, for me and myself at KU and our team, we're saying that triglycerides of 1,000 or less are reasonable as long as there are no other predisposing factors that would increase the potential of the patient having PRIS or pancreatitis. So potentially checking a lipase level, or at least marking the trend of your triglycerides is a really good way of taking care of that. So we would be remiss if we don't touch on pain management. I wanted to just mention a couple of key takeaways. We typically use the CPOT score to determine a patient's pain in ICU. This can be found, we use EPIC, so we have pain assessment doc flow sheets filled by our ICU nurses, and this can be found in our doc flow sheet here. If you have a score greater than 2, then it indicates an unacceptable level and should prompt opiate titration. If you notice the patient's CPOT score is below 2, then potentially this is an opportunity to titrate down on the drip as a means to also conserve medication. Another takeaway would be that if your patient's needs are requiring high rates of opioid drip, or that the patient may be ventilated for more than a week, then really consider adding adjuvant therapies or scheduling medications through the gut. So other ARDS critical care management asks are appropriate PPE. A lot of this is primarily just supportive care. avoiding high flow nasal cannula or non-invasive ventilation. Still, there might be a role for non-invasive ventilation strategies. You just have to consider the risk of dispersion. Glucocorticoids are not associated with a consistent survival benefit and could be harmful if started 14 days or more after ARDS has been diagnosed. In our MICU COVID patients, we have been avoiding steroids unless really using it for other indications such as shock. And then for the management of septic shock and organ dysfunction, per SCCM guidelines, our first-line agent is norepinephrine. Alternative is vasopressin or epinephrine. And if a patient has a cardiac dysfunction, then adding dobutamine. So this kind of concludes just general ARDS management, but wanted to spend some time just sharing what efforts have been done at our institution. So we have focused a lot on our critical care surge planning, and obviously these are ongoing and subject to change, and changes, every week or so. There are a few core members from, physician critical care leadership team, nursing leadership, RT leadership. We have a building called Cambridge, which is separate from our heart center and our Bell. And we are trying to keep more traditional MICU patients there that are not COVID positive, keeping Cambridge COVID free. Our current state is in the main hospital in Bell. All of the 6th floor is our location for our positive ICU, positive acute patients, and then patients under investigation. We even recently opened a COVID triage unit. So if a patient is being admitted from the ED and needs ICU care, they go to this triage unit. There's 9 beds there. And we do have in-house COVID testing. So in less than 24 hours, we're able to determine whether or not this patient should remain on the 6th floor along with other COVID positive ICU patients, or may require a a more traditional MICU bed. And this opened up last Monday, and I think it's gone really well. And because of our turnaround, our ability to triage these patients, we've even been able to downgrade these patients to a med private or another internal medicine team once those tests came back. Future MICU units will potentially involve a lot of our perioperative space, both in the Bell and Cambridge area, and that may increase up to about 50 beds or so, but that is really ongoing and nothing that, we have implemented quite yet due to our census. So other KU initiatives and ongoings, we've really been working hard on our inventory management, like I'm sure many of us are. We're tracking our inventory and just ensuring that we have what we need. We're not only battling what we deem as traditional shortage issues, but also COVID-related issues, because everyone wants the same drugs that we also want. Our pharmacy supply chain has been instrumental. They have created a really amazing tracking sheet. I've created another tracking sheet in which it can determine run reports in terms of how many patients are on certain drips. Caveat that with, what strength vial is being used to make those drips to determine how many vials we would need in 24, 36, 48 hours to kind of do that double check with our supply chain to ensure that we have something on hand for over the weekend, if in case a shipment of something didn't arrive. We also have recurring Wednesday morning meetings to discuss new COVID literature, new medication management options, and then all updates are found in our SharePoint. There are a couple of trials here. Dr. Salate is the chair of medicine, but he's also a pulmonary ICU physician and has done extensive research in everything possible, but he has an IRB approved trial here at KU for losartan. We have had the opportunity to enroll patients in remdesivir, although we are still trying to enroll KU into an expanded program. And then one of our Pulm ICU physicians has submitted a letter of intent to do a trial in which we do remdesivir versus hydroxychloroquine and azithromycin versus supportive care. In terms of pharmacy efforts, we know that mental and physical burnout could occur, and so we also know that in terms of the COVID surge, ICU might be hit the hardest, and we're actively working on training other members in our department to help triage a lot of this gap to provide just more support and having a bigger team to pull from. There's also a group that met this week standardizing our pain, sedation, paralysis. Really the goal of that group is just to be judicious in the use of our meds in each of these categories and create some sort of standardization. As we expand in terms of the number of NICU patients, it will not just be Pulm ICU physicians taking care of these patients, but also anesthesia. So, you know, what has been our ask of those at KU, and I'm sure everywhere else, you know, keep informed, ask good questions, share whatever you have identified as clinical trends. They're really important. And then just be judicious in our resources. Couple of resource acknowledgements. SCCM did also publish a 101-page guidance document, and I will send Jim these slides, and towards the end of it, there are about 11 slides that help summarize the Surviving Sepsis campaign from SCCM as well.